Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the pharmacology of the angiotensin-converting enzyme inhibitors, also called ACE inhibitors. These are antihypertensive drug, and we have ACE inhibitors. We have another group of medication that is called angiotensin-2 receptor antagonist. So another type, angiotensin 2 receptor antagonist. Okay, so these are the drug. We have the angiotensin converting enzyme and angiotensin 2 receptor antagonist. Angiotensin converting enzyme inhibitors are the captopril, enalapril, captopril, enalapril, lisinopril, quinapril, lisinopril, quinapril. Okay, so we have the ramipril, fosinapril, ramipril, fosinapril. So all of them come with the word PRIL. So captopril, enalapril, lisinopril, quinapril, ramipril, and fosinapril. So all of them come with the word PRIL. So these are the drug. These are the ACE inhibitors. Okay. We have also angiotensin receptor antagonist, that is commonly used. This is the losartan. Okay, losartan. Another one is the valsartan. Okay, these two are the angiotensin 2 receptor antagonist. Okay, we got them. Now, what is the mode of action of this drug? We'll give some idea about the Renin-Angiotensin-Aldosterone System. Okay, how it works. This is the angiotensinogen that is produced by the liver. It will be activated to angiotensin 1 by renin. Renin is coming out from the juxtaglomerular cell. Juxtaglomerular cells of the kidney in the tunica media of the afferent arteriole of the kidney cells from the tunica media of the afferent arterioles of the kidney. Okay, we got the renin. Renin will secreted when there will be lack of blood flow to the kidney. Renin is secreted. Okay, that will convert angiotensinogen to angiotensin 1 in the liver. Then angiotensinogen goes to the blood, to the lung, to the endothelial cell. It will be converted into angiotensin 2. Okay, so that is done by an enzyme called angiotensin-converting enzyme, also called kinase 2. This is very important. This is very potent vasoconstrictor. Okay, so this is very potent vasoconstrictor. Potent vasoconstrictor. Okay, so our medication ACE inhibitor, angiotensin converting enzyme inhibitor, work here. It suppresses this enzyme. It prevents the action of this enzyme. So angiotensin 2 will not be produced. That is the idea of this medication, like that of the captopril, enalapril, lisinopril, quinapril, and ramipril and fosinapril. These are the ACE inhibitor, angiotensin converting enzyme inhibitor. So this enzyme will be inhibited. So angiotensin 1 will not be converted into angiotensin 2. Angiotensin 2 itself is a very potent vasoconstrictor. Not only vasoconstrictor, this medication, this angiotensin 2 will also increase the secretion of aldosterone. Aldosterone is a hormone. Aldosterone is coming out from the adrenal cortex. So this is our kidney here. This is the adrenal gland. This is adrenal medulla, adrenal cortex. From the zona glomerulosa, of the adrenal cortex, zona glomerulosa of the adrenal cortex, we are getting the aldosterone. Okay, aldosterone is coming out from that. Aldosterone is a mineralocorticoid. Okay, that is coming from the zona glomerulosa, outer layer of the adrenal cortex. This is the adrenal cortex, adrenal medulla. This is the kidney. So this is our adrenal cortex. It has 3 layers. One is zona glomerulosa, zona fasciculata, zona reticularis. Outer layer is the zona glomerulosa that produces the aldosterone. Okay, so what is the function of aldosterone? Aldosterone keep the sodium in our body, and it releases the potassium along with the urine. Okay, so it maintains the fluid in our body. It keeps the sodium in the body and releases the potassium. Okay, so it keeps the sodium. It also keeps the fluid in our body. So what it does, it increases the preload. So aldosterone increases the preload by fluid and sodium. Okay, so if we can block the production of aldosterone by blocking this enzyme will block the production of angiotensin 2. If you can cut it here, then there will be no aldosterone secretion. So aldosterone no secretion, no fluid retention, no sodium retention. Okay, so rather there will be some potassium retention in the body. So we can cut the preload by blocking this conversion to this and inactivate. Without this will not be formed, and there will be decrease in the preload. Okay, that is, we found that. Okay, so angiotensin 2 decreases the secretion of aldosterone. This is very important. So angiotensin 2 decreases the production or secretion of aldosterone. aldosterone. So there will be decrease in preload, because preload depends on the fluid in our body. So preload will be decreased. This is angiotensin 2 itself is a potent vasoconstrictor. Okay, so if we can decrease its synthesis, angiotensin 2, then we can overcome vasoconstriction. Vasoconstriction will be overcome, so there will be decrease in, if we can cut this, then there will be decrease in afterload. So there will be decrease in peripheral resistance. Decrease in peripheral resistance. Resistance in the blood vessel, especially in the arteriole and other small blood vessel. Okay. Peripheral resistance. Okay, so we got that angiotensin itself is a vasoconstrictor. It releases aldosterone. We can take out that. If you can take out that, then there will be decrease in preload. If you can take out this, then we'll have decrease in afterload. Okay, we got that. Also, the angiotensin 2 decrease the output of sympathetic system. Okay, what is done? It actually increase the sympathetic outflow. Okay, so by this ACE inhibitor, if you can suppress this enzyme, there will be no angiotensin 2, so there will be no sympathetic outflow, so there will be there will be no increase in the heart rate or pulse rate, so no increase in the, so if you can cut that, then no increase in pulse and cardiac output. Okay. By suppressing the angiotensin 2 by this drug ACE inhibitor. Okay, so what will happen? No sympathetic outflow, then there will be vasodilation. Okay, there will be vasodilation. Okay, we got that. So now it is time to summarize. We suppress aldosterone, we suppress the angiotensin 2. So there will be vasodilation and output of sympathetic nervous system will be suppressed. So there will be no increase in the heart rate. Okay, and as because aldosterone retain fluid, we have suppressed it. So there will be no retention of fluid in our body. So what will happen? There will be decrease in preload. So this medication decreases both the preload and the afterload. Okay, so we got that, and we have another substance is released, that is the bradykinin, from the kininogen to bradykinin by kallikrein bradykinin. So bradykinin is a protein. Okay, so that is what will happen. Bradykinin will produce the prostaglandin I, prostaglandin E2. They are vasodilator. Okay, it itself is a vasodilator. Okay, so ACE inhibitor suppresses this. So what will happen? Suppresses the angiotensin converting enzyme by ACE inhibitor. So bradykinin cannot be converted into inactive metabolite. So it will stay in our system. So if it is stay in our system, it will cause vasodilation. It also increases the prostaglandin I2, prostaglandin E2. Plus, it also partly releases the nitric oxide or N0. So this way it causes vasodilation and decreases peripheral resistance. Decreases peripheral resistance, that means decrease in the afterload. Okay, so decrease in the afterload, so decrease in blood pressure. So again, ACE inhibitor suppress or inhibit angiotensin converting enzyme. So bradykinin cannot be converted, cannot be inactivated, rather it remain in our system in active form. So it causes vasodilation. It is converted also to prostaglandin E2, prostaglandin I2. Okay, that also causes vasodilation. That will lead to decrease in peripheral resistance. Decrease in peripheral resistance means that decrease in afterload. Okay, so we have decrease afterload, decrease preload, because we have cut it here and we have cut it here. So we have cut it here. So no vasoconstriction, no aldosterone, no angiotensin 2 because of ACE inhibitor. So there will be decrease in blood pressure and no inactivation of the bradykinin. So bradykinin itself will cause vasodilation. Bradykinin also converted into PGI2, PGE2 plus nitric oxide partly cause vasodilation, decrease in BP. So this is the mode of action of the ACE inhibitor. Okay, we got that. So we got the mode of action of the ACE inhibitor. Okay, so what are the therapeutic uses? Therapeutic use. It is a drug for management of hypertension. It's an anti-hypertensive drug. Okay, an anti-hypertensive drug, especially person with hypertension with some type of heart problem. It is a very good drug. It retards the further deterioration of the heart. So heart failure patient may not, it will not be worsened. Its further damage is prevented by the ACE inhibitor. So hypertension with heart failure is a drug of choice. So further failing is retarded, or further changes, pathology in the heart will be halted or it will be retarded by the action of the ACE inhibitor. Okay, it is a drug for diabetic nephropathy. This is a very good drug. Okay, so it can be used after myocardial infarction. Usually after 24 hours later, it is started to manage a patient with myocardial infarction. Okay, we got that. It is a drug for myocardial infarction. Okay, so, and you have to remember that beta blocker and the ACE inhibitors are not the preferred drug for the African American population or black population. Beta blocker and ACE inhibitors are good drug for the white comparatively young patients. Okay, but if we add the ACE inhibitor plus diuretic, then it will be beneficial, it will be more effective in the African American or black population. So ACE inhibitor plus diuretic. For the white comparatively young patient, ACE inhibitor alone can work better. Okay, we got the therapeutic use. Now we learn some of the pharmacokinetics. Okay, pharmacokinetics. This drug is partially absorbed in the stomach, but it is absorbed quickly, but partially. And it is better to take this drug in empty stomach because food may inhibit its absorption. Its half-life is around 2 hours to 16 hours. It varies from product to product. Okay, it is metabolized in the liver and it is excreted in the urine. So it goes through, it is absorbed through the stomach or upper part of the small intestine like duodenum or jejunum. Okay, so then it go to the liver, it is metabolized, then it is excreted through the kidney. Okay, so that is the pharmacokinetics. It should be taken in empty stomach. Okay, we got that. Now we have to know the adverse effect of this drug. Adverse effects or side effects. Adverse effects. Adverse effects include the dry cough. Very much annoying to a lot of patients. So if it is found around 10 to 15% population, it may be due to the action of the bradykinin that causes the dry cough. It stimulates the afferent neurons for the cough reflex. Okay, so dry cough. There may be skin rash by allergy. But very dangerous is the angioedema in some individual. Angioedema is a devastating condition. There will be swelling of the face, swelling of the tongue that may obstruct the respiratory passage. It may need hospitalization, very quick intervention. Angioedema may kill a person. Okay, we got that. We may have postural hypotension. Postural hypotension. Okay. Postural hypotension, that is the adverse effects. There may be fever because of action of the bradykinin. Angioedema is also action of the bradykinin. There may be fever. Okay, fever, and there may be renal insufficiency and hyperkalemia. Renal insufficiency. So person with gross or end-stage renal disease should not take this medication, or chronic renal disease. Renal insufficiency, although it is a good drug for a patient with diabetic nephropathy, then it will cause hyperkalemia or excessive potassium in the body. Potassium will be very high. Okay, so we need to monitor the patient by looking at the serum electrolyte, and EKG or ECG will get tall peaked P waves. Okay, so we go through that part. Adverse effect: dry cough, skin rash, angioedema, postural hypotension, fever, renal insufficiency, hyperkalemia. Okay, angioedema and fever and rash, it may be due to the action of the bradykinin. If this is the condition, it should be withdrawn, or we may use another medication called sodium cromolyn that may be applied. Okay, so we got the adverse effects of this medication. Okay, so how about another drug, that is the angiotensin-2 receptor antagonist? Angiotensin-2 receptor antagonists actually work on the receptors. Okay, so angiotensin-2 receptor acts on the receptors. on the receptors. It does not block this conversion from here to here. It does not work on the bradykinin. It does not make the bradykinin remaining in the system. It will be break down very easily and it will not convert, it will not work here. So how this work? It just work on the receptor, on the blood vessel. It work on the receptors. Okay, so and in this condition, angioedema rush is less. Rush is less. These are less. This is the advantage, and it can be taken, the losartan can be taken once in a day, so that is another advantage. It is also a better drug to manage the diabetic nephropathy. So it is a good drug for diabetic nephropathy. Okay, so this will be decreased, and it is a good drug for that. That is the efficacy or advantage of the, and no cough here. Angioedema rush and the cough will be also less, because it does not work on the bradykinin system. Bradykinin will be very quickly inactivated. Okay, so bradykinin will not remain in our system. Okay, so it will be inactivated by the angiotensin 2 receptor antagonist. Okay, receptor antagonist, you can say antagonist, like that of the losartan. Another one is the valsartan. Okay, so they block the receptors. They block the receptors of the angiotensin 2 receptors. So does not work on this enzyme system. Okay, very good, we got that. Now we must know something about drug interaction. This drug should not be taken along with the potassium sparing diuretics. Okay, like that of the, you can say, potassium sparing diuretics. Potassium sparing diuretics. Okay, so this is a no. It will cause hyperkalemia. It may cause a lot of electrolyte imbalance. So no potassium sparing diuretics like that of spironolactone along with the ACE inhibitor, also along with the angiotensin 2 receptor antagonist. Okay, very important. Now contraindication. Not only the drug, also patient should take care of his diet or her diet. Diet should not contain potassium rich diet. Okay, that may lead to hyperkalemia. Now we'll go to the contraindications. It is contraindicated during pregnancy, both the drug, both the ACE inhibitor and angiotensin 2 receptor antagonist during pregnancy, because it is teratogenic. It is contraindicated. It is teratogenic. It will cause congenital birth defect. Okay, this is one. Another one is that it's contraindicated in bilateral renal stenosis. So these two are contraindicated. And that's all about the ACE inhibitor and the angiotensin 2 receptor antagonist. If you like my video, please support my channel. Please subscribe me. Any question, please feel free to ask me. Share the information with your friends and have a nice day. Bye now.